But yeah.
Okay.
I've got 3 that are relatively quick, not particularly weird or anything. All right. Here is the first case. I'll put up the frontal and lateral projection alongside each other. This is a patient that quite some time ago had a right lung transplant. And there is a pneumothorax, and a bit of pleural fluid on the right side on the frontal projection. Interestingly, there's also an adhesion that one can see attached to the inferior and lateral right lung. But of course, the interesting finding that just pops out at one are the findings on the lateral projection of Pneumomediastinum. And it's a nice teaching case because just by chance, random chance, there is air in front of and behind the ascending aorta in particular. So we see that nicely. We also see a little bit of air in relation to right pulmonary artery. And for some reason, when people show cases of Pneumomediastinum on the lateral, they often show the so-called ring around the artery sign in reference to the right pulmonary artery, particularly when there's air around it. Here, there's a bit of air in front of it. But this one's just a nice case because in addition to mediastinal air elsewhere, there's the nice depiction of the anatomy of the ascending aorta because there's air in front and behind it. So just an interesting curiosity, a nice teaching case for Pneumomediastinum. He had a CT, I'm not sure why, the next day, perhaps to evaluate more of the pleural space. There's a catheter in there, but there's some residual air in the mediastinum. So a nice case of Pneumomediastinum with kind of a ring around the aorta sign.
So Howard, to me this looks more like pneumopericardium, and a couple of things, and this is what I'm thinking. Maybe I'm wrong, but it's clean looking. There's not the little strands of tissue, and it seems to be going in the superior aortic recesses. And on the lateral, it's such a nice outline, whereas usually, in at least the case I've seen, Pneumomediastinum is so streaky. I don't know, David or...
Okay, so this could be if there's air about the aorta, but it's mostly in the recesses, as you indicate.
Or maybe it's both, but...
Or maybe it's a bit of both. For example, it's a good thought. Let's have a look. Now, this is the next day. There's a bit less air, but that could be a recess. But in front here, there's probably, well, that's hard to say, actually, now that you mention that. Let's look elsewhere to see how much is actually in the pericardium.
That looks pericardial down there.
Pericardial air.
And so was this a fresh lung transplant? Because we had a similar case just this week, and when they do the anastomosis, the vascular anastomosis, it's often intrapericardial, at least the venous component. So it's not uncommon to see pneumopericardium after a lung transplant.
Right. So let's look at that.
I just hopped on. I agree.
This could be a pericardial recess there too, actually, now that I think about it and look at it again. This one maybe not so much, a little, well, this pleural space.
Right there, right on that, scroll down a little, Howard, the image where it's more vertical or horizontal, right there, that's the transverse sinus. So that's, that's the portion of the pericardium that connects the aortic recesses to the rest of the pericardium.
Okay, so most of the pericardium. Pericardial recesses rather than Pneumomediastinum. That's a really good thought. I didn't think about that, but now that you mention that, I think the anatomy could well be that. So I wonder if, that's a good thought. In a general sense, if one has Pneumomediastinum and pleural space air post-transplantation, it's possible that there's often disruption of the parietal pleura, right? So that at least there's a potential for Pneumomediastinum to go to the pleural space, or to be a communication between pleural space and mediastinum after transplantation, right? as well as potentially pericardium. Is that right?
Yeah, you would probably get all three.
Because there are surgically created communications between them. So what about up here? Yeah, maybe most of it, if not all of it, actually could be in the pericardial recesses. Looking at it there and how peripheral it is, that's a really good thought. What about the right pulmonary artery? Well, maybe there's less air on the CT overnight. Yeah, it's a really good thought. I like that, actually. Good thought. All right, thanks for clarifying that.
That's a nice example, though.
Yeah. Okay, this is a incidental finding. This is a case that Leif shared with me a little while back, and I can't remember the sequence of imaging, but the CT is from September of 2017, and the angio is from April of 2018, so they're not in close proximity. But let me just show the CT, where there are some funny vessels. So you can see, let me just scroll down. So we have RCA, and we have RCA there. And then when we go up, there's left, you'll see there's some funny vessels here that go in that direction, anterior to main pulmonary artery. Same thing there. And just about here, there's a little bit of contrast getting into the main pulmonary artery right there. So there's some vessels there. And then anteriorly in the main pulmonary artery, there's perhaps a little bit of a blush right there, kind of subtle. But here is a correlative image from the right coronary artery injection done subsequently for evaluation of that. So there is a communication between some vessels up here, RCA branches or anomalous branches, and then some contrast going into main pulmonary artery right there, unless I'm mistaken. But I think there is a connection between segments of right coronary artery and pulmonary artery.
Wow.
So that's just an interest. I think oftentimes these are incidental findings based on my very brief reading about these, where one can discover fistulae between coronary arteries, left or right, and main pulmonary artery as an incidental finding like this. Right there, right there. So kind of a curiosity.
Yeah, when they're that small, they're often incidental.
Yeah.
And this is presumably congenital, is that correct, guys?
Pardon?
Not acquired, congenital, right?
Congenital, yeah. Yeah, one can find lots of case reports of this kind of phenomenon. Like that. I did not see any coming off the left side towards the main pulmonary artery, just the right side up there. So curiosity. And then this one is just a nice kind of teaching case. Sorry, yep, let me just get this one up. Of a patient that, depending on when you image these patients, they may be going to surgery. But if you have someone that is a male, and let me put this there, and shortness of breath, and particularly if there's a murmur, diminished exercise capacity, I'll bring up the lateral. There are a number of, there's one particular finding here that goes along with the association between aortic valvular disease, and that is a rather dilated ascending aorta. So if you're confident that the aorta is dilated, then one should think of particularly a bicuspid aortopathy, a combination of a bicuspid valve and dilatation of the aorta. This person does not have an aortic coarctation, but does have a bicuspid valve. So depending on the valve fusion pattern, if you have a left-right fusion pattern, the jet of blood through the valve is directed more towards the lateral aspect of the ascending aorta. And it's said that that portion of the aorta, the lateral portion, is the portion that dilates. Whereas if you have, I think, the non-coronary in the right fusion pattern, the jet is directed towards the medial aspect of the aorta and the undersurface of aortic arch, and the dilatation affects that portion of the aorta, depending on the fusion pattern. And then part of the discussion of bicuspid aortopathy is whether there's also a soft tissue or connective tissue component to the disorder, not just the notion of the jet of blood through a bicuspid valve producing this dilatation of aorta. So that's what that person has. And then just to clarify things, just because I read the op report and saw what they did. So they have to deal with the valve, of course. They're dealing with the ascending aorta. So this is a Bronchial procedure in which there is a replacement of the aortic valve and the root and ascending aorta. And this particular surgeon used the combination of this particular stented bioprosthetic aortic valve and the so-called Valsalva graft, where a portion of the graft is fashioned to simulate the geometry of sinuses. And I think there's a theory that somehow this encourages the kind of blood flow that may diminish stress on aortic valve leaflets, but that simulates the aortic sinuses. And then, of course, they put one inside the other. So basically what you end up with is, here is the Valsalva graft. Inside of it is the aortic bioprosthesis. And then they create or take coronary buttons and reimplant the buttons into the graft, so that we end up, in this case, with this kind of anatomy using those two devices. So cool. That's a Bronchial. And if they use the word biological Bronchial, I think it's in reference to the fact that it's a bioprosthesis. And you can use a stented or a non-stented bioprosthesis inside of the Valsalva graft, but this is a stented one in this case, this particular one that they used. So that's sort of conventional surgery for dealing with this situation.
Yeah, the schematics are nice. Thank you.
All right, those are mine for this week. Thanks about the clarification with the pericardial recesses.
All right, well, we have Travis and David, if either of them has cases.
I've got a couple.
All righty.
So can people see a chest röntgenogram here on a woman who's had breast cancer surgery?
Yes.
You sent for a B reading, and she's from Kentucky, and she's got these massive calcified, sort of rim calcified lymph nodes here in the right hilum, and got at least one calcified granuloma down here in her left base. And I don't have any more imaging than this. I don't have a lateral view, and I don't have a CT scan, because I'm sure that we would see in this Kentucky woman that there were calcifications in her spleen. So I believe that this is the sort of thing that Jeff has shown before, of these massive calcified lymph nodes in the setting of histoplasmosis. Here's another granuloma up here, by the way. So Jeff, you've shown stuff like this, as I recall. Is that
right? I have a case of exuberant calcified lymph nodes, milk of calcium, which I suspect this probably has. And
right.
It's rare to get them this big, but it does happen, because in acute histo, we've seen patients with pretty fat nodes.
Yeah. I think the rim calcification and the whiteness but lower attenuation inside goes nicely with that milk of calcium idea.
Yeah.
Yeah.
Okay. Nice.
Caseous necrosis, milk of calcium combo.
Yeah.
Mm. Yeah.
Okay. So
are there funny calcifications, David, in the apical hemithoraces? If you zoom in there, I'm just curious.
Sometimes you'll see pleural calcification up here at the
Are those pleural or vascular, or what are they exactly? They're kind of curious. Just caught my eye now.
Yeah, it's not pleural plaque. That's the important thing to recognize. So the pleura can calcify up there, and I think it's just degeneration. I think when the lung has been hanging there for decades and stuff like that, there's some minor trauma to the pleura. I'm just kind of rationalizing this, and then I've seen calcifications in this thin arc up there. There's not really any thickening, but I think that think it's fairly ischemic up there, and there's traction on it all the time, and I think it just, degenerates and calcifies. So that's my rationalization for this finding. I've seen it mostly in old people. Okay, so that was endemic fungus number 1, histo. And here is a woman who has lived in Mexico and in California and in the Yakima Valley, so east of the mountains here in Washington State. She works in agriculture, and we now have coccidioidomycosis in Washington State, in eastern Washington, that dry area. It's kind of like the dry area in California where there is cocci. And this turns out to be coccidioidomycosis. Let me show you what it looks like on CT. So she's got a cavitary nodule here with this necrotic debris in it here. Seems to be resisting gravity. People are calling this a fungus ball, but I really think this is just necrotic lung. I wouldn't call this a fungus ball. I think it's a cavitary nodule from cocci. And then she's got a pneumonia pattern in the right upper lobe as well. So this was proved to be coccidioidomycosis. So whether she got it in Mexico or in California or in Washington State's hard to know. All 3 places have cocci as an endemic fungus. So fungus 2, this is pretty aggressive cocci. I mean, usually, we will have a couple of smoldering, thin-walled cavitary nodules, but this one is, big and necrotic on the one side and then pneumonic on the other side. Okay.
Yeah.
So here's a person with a subtle abnormality of the chest wall here. This lesion is associated with this anterior chest wall here, and it's pushing into the lung. And this has been slowly getting bigger for the last 8 years. So this lesion's been there for some time, and it really has a lot of big fat vessels in it. And this was finally resected and blocked with a piece of chest wall at the same time. Let me show you on SAG. Here it is coming off the anterior chest wall and pushing in against the mediastinum. This was a cavernous hemangioma that was resected. So that explains the big vessels in this. It's really a vascular tumor. So I haven't seen too many of these. I was convinced it was abnormal when I saw it, but I didn't know what it was.
And can you see where the, I'm sorry, can you see where the vessels are coming from?
I think they're coming from the anterior chest wall because there are a lot of fat vessels in the chest wall nearby. See all these things.
Oh yeah, going through the rib cartilages.
Yeah.
But maybe internal mammary branches. It looks like maybe.
Yeah.
Yeah, right there.
Yeah.
Okay.
So, have you guys seen any of these before?
Oh no, I think this is my first a well-circumscribed cavernous hemangioma. Wow, no, I don't think so.
Okay.
Wow.
And then last, I would like to show you this case of a woman who has a liposarcoma of the abdomen and was receiving immunotherapy with a drug called avelumab. She was also getting an anti-sarcoma therapy called trabectedin, which interferes with DNA and stuff like that. But the avelumab is a anti-PD-L1 ligand agent that sets the immune system going. She'd been on that for 3 months or something like that, and then developed this pattern of a little bit of shortness of breath and very nice organizing pneumonia pattern in the bases with very nice atolls or reverse halos here. So it really looks like, I mean, it's definitely organizing pneumonia radiographically, and they had a hard time pinning this on the therapy because she'd been on the therapy for several months at the point that this developed. But I don't think these things always follow our rule.
It's idiosyncratic, David. I've seen it on people who've been on a long time, short time. It's like amiodarone. It can happen early or late.
Right. Okay. And then here's what it looked like 1 month later, and they hadn't withdrawn the drug, but you can see that the pattern has evolved, and we now have this perilobular pattern of evolving organizing pneumonia. Jeff, you made the point recently that organizing pneumonia clears from the center, and that's probably why we have nice clarity here in the center, but we still have this rim along the edge, and it gives us those, what you used to call arcades, but now it's called perilobular pattern of organizing pneumonia. So things are much better, and I don't think there was any therapy directed toward this. I don't think she got steroids or anything like that. So it seems to have cleared. Now the pulmonologist thought it was, you know, because of the time course of it, thought it might be related to some infection that she'd had, something else set off an organizing pneumonia. But I think radiographically it fits very nicely for organizing pneumonia initially, and then in terms of evolution, I think it's even stronger.
Yeah, that's a nice example.
Okay.
All right.
Okay, we'll see how my connection is here. This first one I want to show, I want everyone's opinion. This is a 44-year-old woman who came into our ILD clinic last week, and she was transferred in with a diagnosis of LAM, not based on anything except the presence of all of these cysts. And I'm going to pose the question, do you guys agree, or do you think that this is going to be something more like amyloid, LIP, light chain deposition? Because I think some of these have a more of a lobulated perivascular look, and I know you can see that with LAM sometimes, but they're not really that random. They seem to be more clustered. I was just curious what everyone, what your thoughts would be on this.
They're more heterogeneous as far as diameter goes.
Yeah,
I like LIP or amyloid light chain much better than LAM.
Plus, some of them have little tissue elements inside them too. Little strands of tissue, which goes along very nicely with the cysts of protein deposition rather than LAM.
What are you saying? I missed the first part of what you said, Howard. You're saying the residual tissue in the
a couple of places you can see little strands of tissue elements.
Like this one here in the left upper lobe.
The more you look, the more you see little strands of tissue.
Like in this one here as well.
Some of them. Yep.
Yeah, okay, good.
Side.
And of course, she doesn't have any AMLs, she doesn't have any intramyocardial fatty foci, she doesn't have any bone islands like you will sometimes see with tuberous sclerosis complex. So yeah, they're gonna work her up, because the only lab they've done, and I withheld this, but they did check a VEGF outside and it was negative, and she's of reproductive age. So that prompted me to go digging, what does that actually mean? This is a nice article from the it's the ATS guidelines for management of LAM. It was in 2016, and they do think that there's evidence to show that VEGF should be used to confirm the diagnosis. And they said if based on the certain levels, and hers was like in the 30s, and they're talking above a level of 800, that you can have a specificity of somewhere around 100%. Now the sensitivities they sacrifice obviously into the 70% range, but I think that's enough, at least to prompt them to do further evaluation, because I think this is probably going to be LIP or light chain deposition. So, okay.
And again, very direct questions about dry eyes, dry mouth, and dental caries, because sometimes people look with that and they don't remark upon it unless you ask them.
Is the dental caries just due to reduced saliva production?
Yes.
Okay, I didn't know that.
Sometimes that dominates the picture.
Let's see this one. Let's see which one I want to show next. I'll show this one. Seth's not on here, but that doesn't mean we can't show some cardiac MR. This is a guy that presented last month. He's 38 years old, previously healthy, no known medical disease. He's of South Asian descent, and he had a syncope while he was lifting weights. Ended up having to be shocked out of a non-sustained ventricular tachycardia twice on his way to the hospital. And I'll start with the MR, because this is kind of the order that things went in. And you see he's got a little bit of this, what looks like just a septal knuckle or sigmoid septum, kind of. That's what it looks like at first. It's a little asymmetric, so you think maybe asymmetric hypertrophic cardiomyopathy, but he's got just some funky motion elsewhere and some areas that are a little bit thinned. I'm going to skip right to the delayeds because this is one of the more impressive cases I've ever seen of delayed enhancement in a non-ischemic pattern. So this is all just patchy, some areas of transmural, some areas of subepicardial, or subendocardial, and even the RV you can see. And I think Jeff has shown a couple cases of profound enhancement in the setting of sarcoid. And of course, then they went and did the CT of his chest, and you'll see here just a gorgeous example of sarcoid with just tons and tons of tiny little nodules in a perilymphatic distribution. It's one of these ones that almost looks like they coalesce into ground glass, but if you zoom in, you can see that these are still tiny, tiny little granulomas, so more of the so-called galaxy sign or just that galaxy configuration. And now I didn't necessarily agree with this. I don't think anyone else in our section did either, because this was pretty much a slam dunk given all of this other stuff. But they did do an endomyocardial biopsy, which also subsequently confirmed the diagnosis of sarcoid. Just because we thought that the pretest probability given both of these findings was near 100%, and the risk of a false negative, what would they do then? But they did get it, and the pathologist said it was one of the most abundant samples of sarcoid that he's ever seen in an endomyocardial biopsy.
Wow.
So
nice case.
Yeah. So
very dramatic. Wow.
Yeah, and I was talking. I didn't really talk about this radiograph. I mean, in the acute setting, I don't think there's anything, because he didn't have lymphadenopathy. There's certainly nothing to slam dunk sarcoid on a radiograph like this. I mean, or even really suggest it just in the acute setting when somebody comes in. But the radio,
yeah.
And he also had a cardiac PET or for sarcoid, which was also suggestive of it too. I didn't include that. This one, let's see, which one is this one? Oh, this is another interesting one. This came into our ILD a while ago, and this is a 50-year-old woman. And Howard, I think it was it you or Jeff a couple weeks ago, or within the last month, that showed a case of idiopathic follicular bronchiolitis?
It was Howard.
Yes.
Yeah.
I did. Yeah.
Well, I've been reviewing a lot of our cases, and this is another case. You can see there's nodules, and this is an outside study, so it's not the best. Some of them you might think are along the fissures, because at least this portion of the minor fissure looks a little studded. But she does have nodules everywhere. And what's interesting about her case, because she eventually had a surgical lung biopsy that confirmed that this was follicular bronchiolitis. And over the past almost 2 years now has had an exhaustive rheumatologic workup, including seeing one of our rheumatologists going through the whole battery of tests, and everything's been negative. What's kind of interesting about her, because it is kind of subtle, she does have some nodules that, mostly centrilobular, but this all happened when she went to Japan, stayed in what she said was a very dirty hostel, and then came back and started having respiratory symptoms. She's been put on a macrolide and then has improved, but the nodules haven't really gone away. So they're still not sure if this could be some sort of post-infectious thing or what else it could be. But there are little centrilobular nodules suggesting a cellular bronchiolitis, and then they did an open lung biopsy and showed that this was follicular bronchiolitis. So at least at this point, presumed idiopathic. So
do you think
not the best.
One of those HTLV3 things like that is a specialty in Japan? One of these human, one of these viruses that was similar to the AIDS virus and stuff like that?
That's a good question. I don't know.
Because that's a lot of lymphadenopathy. Yeah,
that's true. But she hasn't progressed over 2 years. This is the only study I show because it's actually the best looking one that she has. But
I'll look up HTLV3 disease.
Okay. Yeah, that'd be nice if you could. So I don't know if they checked her for any of that stuff, but it was kind of funny because when, the history of traveling to Asia, then it raised the question, was this going to be Asian panbronchiolitis? But, of course, we've seen that. I've seen it twice now in non-Asians, but I don't think it's just association with traveling there. So.
No, Travis, did they test her for HIV?
I will look and see. I'm pretty sure they did. I can check on that later while Jeff is showing cases and get back to you. And then I want to show this one just because David's been showing a lot of cases of fungal infection. And this is a patient who just came in a couple of weeks ago. 82-year-old, and you can see on her radiograph that she has almost just diffuse, what looks like diffuse consolidation, when you just see that it's tons and tons of tiny little nodules that are coalescent. And so this is what it looks like on the CT. And keep in mind, with lungs that look like this, she's not intubated. She has small effusions, but she just has sheets and sheets of nodules that just coalesce into almost diffuse consolidation. Now, everyone was all worked up about this being miliary TB or miliary cocci or some other sort of miliary infection, but the consensus among myself and my colleagues was, when we looked at this, she wasn't that sick, that this was going to be diffuse adenocarcinoma. And I was not convinced that this was going to be infection, even though, you know, cocci can be nasty sometimes, because it's not really miliary. They're more clustered and coalescent in some of these areas. But anyway, we did a CT guided biopsy of this about a couple days after her presentation, and it was just all adenocarcinoma. So this is another case of just diffuse adenocarcinoma presenting in somebody with gradual worsening of symptoms. But really, if this was infection this severe, you would think they'd probably be sick. So that was, to me, the biggest clue.
Yeah.
Wow.
Yeah. And then the other discussion came up too, and I still haven't found a great source on the different mutations that you see in, you know, different presenting patterns of adenocarcinoma, because I've seen references or sources that would say that this is a good look for EGFR positive. You know, Brett was actually saying he's seen sources that Brett Elliker was saying that he's seen sources that suggest that, you know, KRAS mutation can have a look like this. I don't know. Do you guys, what's your sense, or do you even try and get into that?
Not so much, but I think he's right in that the diffuse invasive mucinous adenocarcinoma typically has the KRAS genetic abnormality associated with it. I think, if I remember correctly.
What I think is interesting, though, is, you know, because we see different patterns of diffuse, right? Because sometimes you'll see more of that pneumonic, where it's just diffuse ground glass and even consolidation and crazy paving to some degree, whereas this is just diffuse nodules. So I don't know if that also has, you know, something to do with it too. I don't know.
Yeah, I don't try to make the distinction. I've seen papers trying to look into this, but a lot of times, like I noticed, I mean, even the histology is mixed. You know, you get these micropapillary acinotypes that do weird things, but there's probably some overlap. But I think, yeah, but as Howard said, the KRAS is much more common with the mucinous tumors, if I remember.
Yeah, I know over the last couple of years there have been a few RSNA exhibits trying to group all of these presentations into, you know, into different mutation patterns. But I don't know. I agree with you, Jeff. I think there's a lot of overlap. I don't think it's as easy as just saying one is equal to the other. So, all right. Well, I'm going to show, this will be the last one I show here. This is a recent congenital case, and this patient was born a couple weeks prior to this study at an outside hospital. And you'll see as I scroll down, their situs is normal. They have a left arch. They have a right superior vena cava. The first thing you notice is that their right atrium and right ventricle is huge. And then this is really cool, because when you look at the pulmonary veins, it looks like the left side of pulmonary veins cross midline. It's almost one of these midline common osteums that we've seen that I've shown in adults. But what's interesting about this is, notice where the contrast is. This is actually the interatrial septum right here. And it's almost, as the surgeon was saying, and you can see it goes all the way up to the roof of the left atrium. And so all of the pulmonary veins actually insert to the right of the septum. And when we were discussing this in the preoperative conference, there is a small little, well, not small, but there is a patent foramen ovale. But if you look at the axis of the ventricle, you know, the axis of his heart should be like this. And so the surgeon was commenting on that it looks almost like it's just the axis of the atrial septum has deviated and migrated leftward. And so you're essentially getting a PA, or a total anomalous pulmonary venous return from, you know, from this just weird placement of the interatrial septum. And so this actually turned out that that's what this actually was. It was total anomalous pulmonary venous return, an intracardiac type. And it turned out to be a fairly straightforward surgery, because the surgeon found in there, in the operation, was a completely formed atrial septum. It had all of the parts. They were just migrated to the left. And so he basically just recreated, essentially moving it, or moving the position of it and using some pericardium to recreate an atrial septum, in the expected location. So I don't know. I can't remember the last time I saw an intracardiac total anomalous pulmonary venous return, if this is what happens in a lot of those cases or not. But I just thought that was kind of an interesting developmental abnormality.
So where is the left atrium again in this person?
So yeah, I'll show it on this venous face because I think it shows it a little bit better. So the left atrial the interatrial septum is just deviated left. It's right here. So the left atrium is just this small little chamber. It has an appendage.
Yeah.
But the right atrium has just overtaken all of that, and then the pulmonary veins, they cross midline to insert here on the right side of this interatrial septum.
And on the back of the atrium.
Yeah.
Wow.
Yeah, so there is an interatrial septum, and there is a left atrium, because you can see it here, and there's a formed mitral valve. It's just, for whatever reason, the atrial septum just decided to take over most of the left atrium. So I was hoping Seth would be here to see this, but I thought it's just a really interesting case.
Yeah, that's neat.
So,
all
okay,
right.
Jeff, I will stop there.
All right, thanks, Travis. All righty, let's see what we can do. All right, so this is a cool case. David has shown something like this before. Yeah, we don't need that. All right, so this patient needed a port placed, and so had a port placed, and this is the spot image taken during the procedure, and if I get my mouse to behave, there we go. And this was a power port, and you can see it has the letters CT written here, and that's an indicator that you'll see these on all the different port models, that it's a power port that is rated for 4 or 5 milliliters per second injections. There's the reservoir. And so about 2 weeks later, they were having trouble accessing the port when they wanted to use it. So they sent the patient for a chest radiograph to see if the port was okay. And you can see the catheter is tunneled, IJ, it's intact, it's terminating in a low normal position. But you will now notice that the letters C and T are mirror imaged. The T looks the same, but the C is now backwards. So this port flipped 180 degrees.
Yeah.
And I learned this from you, David, that you showed a case years ago of the backwards letter. So I learned that from you, that along the vertical axis. So the back of the port is now facing the front of the patient, so their little needle can't get through it because they're often metal on the backside or solid material.
So I thought I was the only person who'd seen that before, and it was pointed out to me when I missed it by John Harley, who was placing these ports at the SCCA at that time after retiring from the VA after decades. So he was placing these things, and he called me up and said, the reason they couldn't inject this port is because the thing has flipped over under the skin and the back is facing out now. They try to inject the back, it won't work. And I had never heard of such a thing. So I was very embarrassed by having not understood that and not anticipated it. And now you've come up with another case. That's wonderful.
Well, it was great because I knew what to look for, because I've seen disconnected ports, migrated catheters, things like that. But we know exactly what to look for. So
David, we had one too. So, and within the last year, and I credit you for pointing that out because I didn't know what to look for either.
Well, so I thank John Harley. So he's the grandfather of all of us in this.
All right. Okay, so this is a cool case. So this is sort of a mini companion case to David's vascular tumor. So this is a patient who has renal cell carcinoma that was treated some time ago. I want to say the nephrectomy was like 7 or 8 years ago, and had no metastases. And this was just a routine surveillance. And we picked up this little guy here. And the reason I'm showing is, first of all, because we all know renal cells can be really sneaky. But I thought this was cool because you can see all the vessels that this thing is parasitized. So it's a very hypervascular tumor. And it's just right along the trapezius. and all these little paraspinal vessels are coming in and out of the tumor. It turns out the patient actually had pain at the site at her clinic visit that day, so they're going to probably just locally ablate it because it's her only site of disease at this point. She's clearly had an indolent tumor, but renal cells, the longest I've seen is like 20 years after nephrectomy with metastasis showing up. Other ones you might think about doing melanoma, but they tend to be a little bit more aggressive across the board. The other differential would be other vascular tumors, but in this setting, this is a nice example of this. And easy to miss. Interestingly, we found a second one the same day. One of my colleagues did, more subtle than this one, because this was high on our radar. So but just kind of really neat to see the vasculature from the chest wall going into these. Wow. All right. So this is another congenital case, and maybe I just have never noticed this in the past. Let me get my magnifying glass here, make this bigger. But so this is a case of nothing exciting. This was just an incidental finding. I was looking back at a radiograph. We were reading a radiograph and saw the CT and noticed on the CT this vessel. And I always tell the residents I have a rule: there's no vertical vessels allowed lateral to the aortic arch, and this is why. It's either an SVC or anomalous venous drainage. In this case, it's anomalous venous drainage, the left upper lobe. But the reason I'm showing it is, to me, there's one vein coming into this vertical vein at this location, which is what we typically see. But I kept following it down, and I was thinking, oh, this is going to be connected to the left SVC, but it doesn't do that. But it has a second or pair of branches or branch that comes in from the lingula. So it's a complete left upper lobe partial anomalous venous drainage. There is no left superior pulmonary vein. As you can see, there's the inferior, the appendage, but no vein. But this is the first time, at least, I've noticed a separate vein draining from the lingula into this vertical vein, as opposed to the one we usually see at about this location. Have you guys ever seen that?
Now I wonder whether I've missed something like that.
That's what I'm wondering. So let's see if I can show it there on the corona. There it is. So you can see there's this vein coming in, or maybe it's just a late. I guess it's not an early branching, but it's kind of a late fusion or coming together of those veins. But you can see the separate vein coming in right there. And maybe there's actually, I think, two. I think you've got this branch and then this branch more medially that drain the lingula right down in there. I guess I can make a MIP as well. But yeah, I'm now, every time I see one of these, I'm gonna have to start going through the details of what exactly is. It's hard to show on the MIP, but what's coming in. But I thought that was kind of cool. I couldn't find any other anomalies to go with it, but all right. Here's a good infection case. So this has a great history. The history is hadn't seen a dentist in 20 years. So it was transferred to our institution with this outside CT, which the contrast isn't great. It's a little bit noisy, but you get the picture. And there's this abscess cavity down the right lower lobe. As a matter of fact, I think there's two abscesses because I could see that there was a little band of tissue in between. This one has gas, but what I noticed was this little flash of contrast. And if you scroll quickly, gently through it, you can see that it sort of branches right there and there. And this was not appreciated on the outside. And the reason this case was even sent to us to look at is they were admitted to a general service. And the question was, is to TPA this pleural effusion, which to me, I mean, may or may not be infected, but and of course, we don't like to put things in lung abscesses, but rather manage them medically because of risk of bronchopleural fistulas and spillage and stuff like that. But this is somebody you definitely don't, first of all, you don't want to put anything in this anyway, but you sure don't want to be TPAing this. If there's any potential that it communicates with the pleural space, there is gas in here, which would make me a little suspect. And so this is being treated medically, but it was funny because with the history, they did do a Panorex, and you can see these are pretty bad teeth. There's a bunch missing. There's been a lot of work, and there's actually a cavity, a big cavity right there. So it's not. I don't think it's actino. It's acting more like a pyogenic abscess. But bad teeth, aspiration, anaerobes, all sorts of bad stuff like that, causing a pseudoaneurysm. And I've seen these get better with treatment. The pseudoaneurysm thromboses. And doesn't necessarily, and there you can see it branching on this coronal. It doesn't necessarily require embolization right away, but you have to have a low threshold, because if they start getting severe hemoptysis, you'd probably want to go right to IR and have that embolized and not mess around with it.
Mm-hmm.
Okay, this was a case that my colleague shared with me. This was a patient who was on for a TAVR conference. You know, they meet and discuss them, and so this was the TAVR workup. And as my colleague was looking at this case, talking about the aortic valve, this is a patient who already has a valve prosthesis in, and I'll change the plane, but you'll first notice that there's the little struts of the valve, but the base of the valve has a funny orientation. But then as you scroll down, you realize there's a little collection down here that doesn't belong. So if I do a coronal, should run this pretty quickly, you'll see that actually this is another example. And I'm sorry with the overlap there. Let's see if I can bring it out here. This valve, there's a perivalvular leak, and the valve itself is sort of dehisced. It's almost not quite floating, but it's not in its normal place. They're the native leaflets. There, what's left of them. So this went from a TAVR case to a surgical case, but so very tricky. I mean, it's easy. It's easy to miss stuff on tops and bottoms and axial planes, and always important to use multi-planes to look at this stuff. But a nice complication of that. Now, this is a case, I don't have path proof, but I went back and saw this. I saw this finding, and I went back and saw it over serial exams. I only saved one because it shows the same finding. And I think it's incidental because this is a patient who's had asbestos exposure. I don't remember why the CTs are done. It was surveillance for metastases or something that they don't have. But I noticed in the lower lobe, there was this chronically filled airway in the intermediate basal segment, and it had been there for over many years and never seemed to get infections there. But what was cool is when you look at it on the soft tissue windows, you realize it almost looks, it's very low attenuation, and you can see right there it's actually fat. So I think this is an endobronchial lipoma causing some distal obstruction, and I've seen one of these before. The one I saw before actually caused recurrent infections, but this one not. So I kind of, given it had been there for a while, it's an older patient, I just kind of left it with the comment, just I wouldn't do anything about it. But if she has a history of recurrent infections, it might be worth seeing an interventional pulmonologist. They can probably snare that thing and pull it out and be done with it. But they're described, and this is only the second one I've ever seen of a nice endo, but I'm presuming that's what it is, given that it's been there for years and really hasn't, and it's always in the same place, not a big aspirated fat blob.
And it doesn't, the other thing is it doesn't look like fat in a hamartoma, because it doesn't look as if it's part of a mass. It looks as if the fat, the whole thing. Right,
exactly. Hamartomas, you sort of, usually you see other tissue mixed in, and this is very bland. If I zoom in, you can see it's really homogeneous. So it's a presumed endobronchial lipoma. I don't think I showed this case yet. I've been saving it for a while, but this was just cool. This is a patient with cystic fibrosis. I haven't shown this case, have I? With the
I don't think so.
Stop me if I do. Not a great scan, breathing all over the place, but has pretty bad bronchiectasis in the upper lobes with these large cysts/cavities. What I really liked about the case, though, was just the striking bronchial arterial hypertrophy, and I've even got an angiogram. So the reason they did this scan was the patient was having hemoptysis, and it's rare to never that you see much. There's maybe a little blush right there, but usually the CT doesn't help very much because it's either they have massive hemoptysis and the radiograph kind of gives you a hint of where it's coming from, but you don't see the active bleeding. But these are just big, juicy bronchial arteries. But if you look, there's maybe a little bit of blushing on the right in this general vicinity. But I have I liked it because it was impressive. But here's the angiogram. It's a little too fast, but you can see quickly just there's blush of contrast, but it's just markedly dilated, and there is a little bit of blush there. So they treated this with some embolization, but one of the complications of bronchiectasis is hemorrhage from bronchial arterial hypertrophy. And I presume that they're high pressure, there's chronic inflammation, the walls will get compromised and or infected or something, and there's a little tissue breakdown, or there's lots of vigorous physiotherapy as well to try to clear these airways that maybe they ooze or leak, and patients can come in like this. But so CT, if you get a good aortic phase, can be helpful. So this, you can see, was a little bit later phase, rather than going for the pulmonary arterial phase, or at least get a dual phase, because you can really pick up those bronchial arteries.
Hey, Jeff, what was that one large vertical artery on that selective injection? Is it just going along the descending aorta?
You mean this one right there?
No, it was going down. Where's the subtraction image you showed? Yeah.
Oh, right there.
It's going all the way down, because when you were showing the, see how it kind of goes almost to the diaphragm?
Yeah. That is a good question. I didn't dig into that. Let's see if we can find it on the CT. I wonder if it's a collateral pathway coming up. Well, there's a branch coming off the descending aorta, but that went lower down.
Because one thing when you were scrolling through was just, it looked like higher up that, what are those vessels superficial to the right internal mammary artery? Is that a vessel in the anterior chest wall?
Right there?
Yeah.
Yeah, that's coming off. Or is that a?
Yeah, I was trying to figure out, because occasionally we'll see. Wow, what is that?
It looks like it's going into the internal jugular vein.
Huh.
Because that's a good question. That looks like shunt tubing.
That looks like a VP shunt or something over there.
Yeah, that's a fragment of a shunt, but this looks, maybe that's what that is, but or I don't know what that is. Unfortunately, I didn't have a radiograph of this patient, so never got to figure it out.
I was just curious, because sometimes...
Yeah, there's the shunt fragment. There's the shunt fragment there. Yeah. But yeah, there's a central line in, but I don't know what that is. I mean, if we look at it.
I think it's a calcified VP shunt.
Yeah, but what Travis is talking about is this vessel right there. I think, is that a spinal? That's too lateral, but see, it looks as though there's side branches.
Well, because
I don't know.
Because that catheter almost, the course of the catheter looks like is it engaging something in the ascending aorta, a bronchial? Or is this just a weird projection?
Internal mammary, maybe?
That's what I'm wondering.
Yeah, they did a bunch of runs. I just grabbed the one that showed the best. I think they went off the internal mammary, and that's why it's so high. And that's what you're seeing there. But the bronchial is...
Yeah, so can you see any collaterals from that?
Jeff?
Yes.
It looks as if it goes intact all the way down to the diaphragm and then branches. I think it's a pericardiophrenac artery.
It almost looks like this vessel right here.
Go back to the angiogram. See how it goes. It doesn't. I don't think it's giving branches at the intercostals, and I think it goes all the way down to the diaphragm and then branches. So I think doesn't that look like pericardiophrenac artery?
But doesn't that usually curve? It might be, but I wonder if it's the internal mammary, because if you follow the internal mammary,
that's what I think.
It's straight. See how it's very straight, David, right there? No branches, and then you get right to the diaphragm, and there's one branch going off, and then there's another branch, and that matches up with the angiogram, right? That's going to be there.
Okay, I thought we should be seeing
there. There's that medial branch, and then there's the lateral branch.
Okay, that makes sense.
Yeah, but I think with these cases is it's hard to figure out where stuff's coming from, because if you look, there's all this collateral up here too, and
there's one coming off of the right subclavian artery, right at the inlet, right there.
Right there, yeah.
And I wonder if that's what they're injecting in this case.
Yeah.
Well, because I think that's the point. One of the utilities of these studies too is just finding non-bronchial collaterals that they have to go after.
Right. Right. Mm-hmm. Yeah, they don't always come off the aorta, so an aortogram alone may not be enough. Okay, well, think I'll stop there. So thank you, everybody.
Thanks, guys.
Thank you.
See you next week.
Thanks, everyone.
All right, talk to you later.
All right.
Bye-bye.
Bye, everyone.